Hello and welcome to the next lecture on restless leg syndrome for POD4MCF. My name is Matt Dilnot, as you probably know, and we're going to be going through a brief overview of restless leg syndrome and what it means for clinical management. So just to define restless leg syndrome, it is also known, but not well known, as Willis-Ekbom disease from two physicians who were involved in characterizing and writing about these diseases some time ago. It is a neurological condition characterized by an irresistible urge to move the limbs to alleviate a sensation of dysesthesia or hyperesthesia. It is typically characterized also by a worsening of symptoms of the dysesthesia and hyperesthesia at rest or at night time. So people might complain of this condition when they're sitting in a theatre and it's quiet and they start to notice a feeling of pins and needles or creeping sensations on their legs. And when you get abnormal sensations, we call this dysesthesia. And this may be, as I've just said, burning, itching, electric shocks. But some people may notice or just notice hyperesthesia. This is where they just get increased sensitivity of the nerves, and you will see this in other conditions where you have injured a nerve and you may start to get hyperesthesia. One of the conditions that you may think of is complex regional pain syndrome type 1. So Willis-Ekbom syndrome, or RLS as we now call it, was first described by Thomas Willis in 1685. No significant development in research at that point until fairly recently in 1944, where Dr. Carl Axel Ekbom wrote a number of papers on it. And then further research in regards to the use of dopamine, so levodopa, which is an exogenous form or a pharmaceutical form of dopamine, and the use of dopamine agonists, in other words, drugs that make your dopamine work better. He researched that as a treatment for restless leg syndrome. And overall, just to cut to the chase here, the results of treating restless leg syndrome with dopamine are generally pretty good, but if you keep using it for a long time, it can actually augment, in other words, make worse, the RLS symptoms. So most studies around the world have given a general prevalence of RLS of being around about 7%. Now, when you look at that figure, a lot of people may occasionally get it, but don't consider it to be a significant problem for their lives. But roughly around about 2 to 3% of people feel it has a significant impact on their life. And that basically is an issue with going to sleep at night. It keeps them awake, it causes jerking movement of their legs. And of course, it's one of those conditions that patients may actually mention to you to say, oh, I get restless leg syndrome. So the ratio is women 2 to 1, so twice as many women tend to get this condition as men. So there's a reasonable likelihood, with roughly 7% of the population affected, that you're going to see patients who complain about it. And it's useful to know what the management is and also what the differential diagnoses are. So generally there are two forms of RLS. There is an early onset form, which they define as being less than 45, but generally the peak age is around 20 to 40. This is often familial, so there's a genetic family history of this condition, and typically it progresses quite slowly. But then there's also another group of people that they call late onset, which is after 45, and this is less familial, and its progress is more rapid. And this is more commonly associated with an iron deficiency syndrome or problem. So we'll talk about that a little bit later. So just to summarize briefly how this condition develops, or how they believe it develops, is that we know it happens within the central nervous system. And currently the main hypothesis around restless leg syndrome is that it is related to low iron levels in the brain, which then leads to dopaminergic dysfunction. In other words, your dopamine's not working as well or normally in the central nervous system. And it appears that there are genetic predispositions to developing this low iron level. So this can also occur in people with chronic renal failure, anemia, and during pregnancy. So these can actually trigger low iron levels, and that can ultimately lead to low iron levels in the central nervous system. Because this condition is actually quite common, so you're going to see obviously 1 in 20 people thereabouts who actually experience this syndrome at some point in their life. There is actually an International Restless Leg Syndrome study group and association. And in order to, I suppose, confidently diagnose this condition, they have set up some diagnostic criteria. And basically those criteria are as follows, which is obviously an urge to move or unpleasant sensations in the body part. And as you can see on this chart on the right here, you can see that the frequency of issues are mostly in the lower limb. They do occur in the upper limb, but more primarily in the lower limb, so they're more likely to be talked about to a podiatrist. And as you can see there, predominantly you're going to start to notice more issues with the calf muscles. We'll also see that their symptoms are typically relieved by activity. So when you're moving, it seems to lessen or dampen down the sensations that they are feeling. It also triggered by rest, as we discussed. It is worse in the evening. And importantly, in order to diagnose this, we need to exclude other things that mimic restless leg syndrome. And one of the most common ones I would see, and you will see, is venous disease. So when people have varicose veins or a history of past DVT, which is causing poor flow through the veins in the legs, this can sometimes mimic restless leg syndrome. Leg cramps, which can happen for often unknown reasons, can also mimic restless leg. And there are some people who just through either obsessive compulsive disorder or other reasons can often have just habitual movements, which they sort of get into the habit of doing, just moving, twitching their legs, which some may think is actually a restless leg syndrome but isn't. So the International Restless Leg Syndrome Severity Scale does exist, and that basically categorises RLS from mild to very severe. And they have a point scoring system which you can look up. One of the key criteria that's worth remembering is something called periodic limb movement in sleep, which occurs in 90% of people with RLS. So in other words, quite significant jerking of the limbs, or uncontrolled jerking of the limbs whilst people are sleeping, which obviously in some cases can cause quite significant problems with sleep quality, and obviously may disturb partners. And peripheral neuropathy is seen in about 40% of people with restless leg syndrome. So it's just as a differential diagnosis, nocturnal leg cramps, so there's no abnormal sensations, just cramping is a differential diagnosis for RLS. Peripheral neuropathy is also a differential, but remember that in peripheral neuropathy, like what you might get with diabetes, it is not circadian. In other words, it doesn't get worse at night time or whilst in bed or whilst resting. So that's a fairly easy one to differentiate. Venous insufficiency, which we've spoken about. Parkinson's disease, particularly in the early stages, can be tricky to differentiate from RLS. Periodic limb movement disorder, which is actually separate from RLS, can also occur, but again, this condition does not have the abnormal sensations, that dysesthesia or hyperesthesia. You can get iron deficiency without RLS, so clearly people can be iron deficient and they won't get the restless leg syndrome, and they won't get circadian worsening or sensory symptoms as well. And sleep apnea can occasionally cause leg discomfort, which may make people confuse with RLS. So the risk factors associated with RLS are fairly obvious now. We've got iron deficiency anemia, which makes sense, chronic diseases such as kidney failure, possibly Parkinson's disease, which can be associated with RLS, and other conditions which might lead to low iron or abnormal iron levels, such as pregnancy, can also be included. So management strategies. So there aren't a lot of significant management strategies at this point. The non-pharmacological interventions which you might suggest to your patients is something around sleep hygiene, which is obviously getting ready for bed in a way which is calming, helps you settle into sleeping effectively, meditation, reading a book, keeping the lights down low, etc. They possibly can help you to go off to sleep easier, and so you can potentially ignore some of those hypersensitivities or hyperesthesias and dysesthesias that you're feeling. And you can make lifestyle modifications. Increasing activity during the day possibly helps with reducing issues at night time. Then there are the pharmacological treatments. And so the pharmacological treatments that they often talk about are dopamine agonists. So we've spoken about those already. So dopamine, we're increasing the dopamine in the central nervous system, and that seems to settle the nerves. That can reduce those symptoms of RLS. But unfortunately, if we continue to use dopamine agonists or dopamine, that can actually cause augmentation of their symptoms in the longer term. So they need to be used judiciously, perhaps just using them when things are worse and using them less when things are better. There's also something called alpha-2 delta calcium channel ligands. So you may know them as gabapentin and pregabalin. So that changes calcium levels in the neurons and alters neurotransmitter release. Again, they have lots of side effects, these drugs. They're not typically well tolerated, but on the plus side, they don't cause augmentation. So if they do help people to settle their nerves so that they don't cause significant hyperesthesia, then it may be a viable option for some patients. Generally, for me, I've found that people don't tolerate them for very long because it does make them feel a bit odd during the day. And clearly, if someone has iron deficiency, supplementation is a worthwhile treatment. There are some drugs that can worsen some symptoms as well. So antihistamines, especially sedating antihistamines, which you have access to, you have access to one of those as an endorsed podiatrist, that can actually make symptoms worse, unfortunately, because it does change dopamine function in the brain. There are dopamine receptor blockers used for things like schizophrenia, which clearly, being a dopamine blocker, will also obviously increase the chance or risk of developing RLS. And there are some antidepressants which might also worsen the condition. So, complications and prognosis. So, symptoms tend to worsen with age, unfortunately, especially if it's untreated or poorly managed. We know it has a significant impact on the quality of life in around about 2 or 3% of the population. So this can lead to poor sleep and excessive daytime sleepiness, which obviously then potentially might lead to depression and anxiety when you're getting a particularly bad attack of this condition. And there are obviously long-term health risks associated with sleep deprivation, so that may contribute to cardiovascular disease issues, particularly with hypertension. We've spoken before about the risk of augmentation with long-term treatment with dopamine agonists. And the prognosis overview, so while some patients stabilise with treatment, unfortunately others experience progression, and none of the treatments so far are particularly, they're not curative. So it is a tricky condition to manage. So looking at future directions in RLS research, there are some emerging treatments in non-dopaminergic options. So basically drugs that are targeting non-dopaminergic pathways, and they're called glutamate antagonists. I don't think you really need to know that, but just know that they're actually trying to find other drugs to treat the dopamine issue. Gene therapy, very slow, very long-term intervention, which is at this stage quite primitive. So I think there's quite a long time before we'll start to see gene therapy. Neuromodulation techniques. So you may have heard of transcranial magnetic stimulation. It's a reasonably safe treatment option. So that can be helpful for severe cases. And deep brain stimulation, which they often use for treating Parkinson's disease, is also a potential option, but that's a more significant intervention and a little bit dangerous. And then there's also potentially improved iron supplementation forms, so trying to come up with new delivery systems to try and improve the iron levels in the central nervous system. So that's something else they're working on. So clearly there are some gaps in current understanding. So the pathophysiology lacks a bit of clarity around the exact mechanisms by which iron deficiency leads to dopamine dysfunction and sensory disturbances. We don't really know why supplementing dopamine through drugs or agonists to improve the function of your dopamine, why it causes augmentation. So we probably need to come up with more personalised care for individual patients, and this would be ideal if we could come up with exact treatments specific for patients' needs, depending on exactly what the issue is, whether it's a genetic risk or an iron metabolism issue. And at the moment, we've probably been using dopamine agents for around about 20 to 30 years, but we don't know, for people who've been starting to use this sort of treatment in their 20s or 30s, we don't have the long-term data to show how these people are going to end up in another 40 or 50 years. I think one of the best things we can do, though, is enhancing our understanding and helping our patients know that they've got restless leg syndrome, and helping healthcare providers to recognise this condition early, so we can start to get people into good habits in regards to sleep hygiene, and also avoid unnecessary treatment because they've been misdiagnosed with something else. So I think if we can know a little bit about restless leg syndrome, you will talk to your patients about it at some point, and it's good to have a bit of information just to make sure you're giving them some reasonably accurate information so that they can seek out some better treatment options. So just as a summary, I think we can understand the core features of RLS, which is that irresistible urge to move the legs, accompanied by unpleasant sensations, and they're typically worsened at times of rest, and particularly in the evenings or at night time. The pathophysiology we've mentioned is essentially what we believe to be iron deficiency in the central nervous system, which is probably predisposed to in a lot of people by genetic factors, but in other people because of changes in their life, such as pregnancy or kidney function or anemia. The diagnosis, as we said, we do have the criteria to diagnose it, which you can look at. Management we've spoken about is the sleep hygiene, and the complications that we might want to be looking for or thinking about is because of the significant impairment in quality of life through poor sleep, this can lead to other mental health issues and hypertension and cardiovascular disease. And then leading on to that, we've got possible future directions which to improve dopaminergic treatments and possibly other treatments and possibly the use of other forms of iron. So the message from the International Restless Leg Syndrome group is that we should be looking towards early diagnosis and preferably tailoring management options to the specific needs of patients so they can get on top of their problems early, or leaving them till they're too late and they've already started to develop other health issues. Thank you.